Bronchiolitis is an acute viral lower respiratory infection of the small airways, the bronchioles, in infants and young children. Classically, 2 to 6 months old, and most prevalent in the fall/winter months. Characterized by mucosal edema, sloughed epithelium, and mucus plugging that narrow distal airways and produce air trapping, atelectasis, and ventilation perfusion mismatch, with tachypnea, wheezing and crackles, and increased work of breathing. RSV is the leading cause, but rhinovirus, human metapneumovirus, parainfluenza, influenza, and adenovirus are also common triggers. Co-infection with multiple viruses can occur and does not reliably change outpatient management. Illness typically begins as a URI, rhinorrhea, congestion, low-grade fever, and progresses over 2 to 3 days to cough, tachypnea, subcostal intercostal retraction, nasal flaring, and feeding difficulty. Apnea can be the sentinel sign in very young or premature infants. Exam findings are dynamic. Wheeze, crackles may vary breath to breath. The expiratory phase is often prolonged, and pulse oximetry may show mild hypoxemia. Severity usually peaks around days 3 to 5, with a cough that can persist 2 to 3 weeks. Diagnosis is clinical during respiratory virus season. Routine labs, viral panels, and chest radiography are not indicated in typical cases. Chest X-ray often shows nonspecific hyperinflation peribronchial thickening and can prompt unnecessary antibiotics. Think differentials when features are atypical or focal. Asthma reactive airway disease, usually in an older child, atopy, clear bronchodilator response. Whereas bacterial pneumonia has focal crackles, high fever, and lumbar consolidation. A foreign body aspiration is sudden in onset with unilateral findings. Pertussis has paroxysm, post-tussive emesis, or cardiac structural lesions, which usually present with vascular rings or tracheomalacia. Assess the risk and disposition by work of breathing, retractions, grunting, head bobbing, the feeding and hydration. Do they have a reduced intake? Do they have a decrease in wet diapers? And oxygenation. Do they have a sustained pulse ox that is less than 90%? High-risk groups are those with an age less than 12 weeks, prematurity, bronchopulmonary dysplasia or chronic lung disease, hemodynamically significant CHD, neuromuscular disease, immunodeficiency, exposure to tobacco smoke, or crowded housing daycare, and these warrant lower threshold for escalation. The management is supportive, with frequent nasal saline and gentle suction, especially before feeds and sleep. Hydration with small, frequent feeds, and consider NG or IV fluids if the oral intake is poor. Use antipyretics, parental education, and oxygen to maintain saturations greater than 90%. Inpatient pathways may use high-flow nasal cannula for moderate to severe distress and hypoxemia, with escalation to CPAP and the ICU as needed. Therapies that do not improve routine outcomes and should not be used routinely include albuterol, epinephrine, systemic or inhaled corticosteroids, antibiotics unless a bacterial process like acute otitis media or bacterial pneumonia is present, chest physiotherapy, and over-the-counter cough-cold medications. A single albuterol trial can be considered only when an asthma phenotype is suspected. This is someone that's an older infant with a personal or family atopy and a recurrent wheeze. The albuterol should be stopped absent of any objective improvement. Outpatient criteria include mild work of breathing, adequate oral intake and urine output, reliable caregivers, and ready access to follow-up. Provide explicit return precautions, for example, worsening retraction, poor feeding, apnea, cyanosis, lethargy, or a persistent low pulse ox below the target range, and any dehydration. And plan 24 to 48 hour reassessment for moderate symptoms or risk factors. Prevention is high yield. Nirsevimab is a long-acting RSV monoclonal. As a single IM dose, is recommended for all infants entering their first RSV season, and for select high-risk toddlers entering a second season, for example, those with severe prematurity, chronic lung disease of prematurity, significant CHD, and marked immunocompromise. Polyvizumab has been around for a while and remains an option monthly for specific high-risk infants when nirsevimab is unavailable or per specialist protocol. Additional measures include maternal RSV vaccination during pregnancy, seasonally timed, annual influenza vaccination for children greater than 6 months, with 2 doses the first season for vaccine-naive children 6 months to 8 years, meticulous hand hygiene, limiting exposure to sick contacts, and eliminating tobacco smoke exposure. Overall, remember the mantra for boards. Diagnosis is clinical, treatment is supportive. Escalate for hypoxemia or feeding failure and avoid ineffective medications.